Welcome to a new DIERS International online tutorial. In today's part, we cover the dynamic spine measurement with the 4D motion system. The functional diagnostic approach, which is concerned with the observation of movement patterns in partially standardized test procedures, has already aroused early demand in the user group of video raster stereography for the visualization of a postural construct in motion. Initial attempts, such as the implementation of functional tests, like the posture test according to Matthias, have added considerable value to the optical spinal measurement and are still part of the product today. Further development by the examination types 4D Dynamic and 4D Dynamic Plus then paved the way for the calculation of a moving spine model. Unfortunately, the capacities of the recording units via the then prevailing USB 2 standard were quite limited. Computer performance was also not capable of showing a 3D model of the torso in fluid motion. It was not until the introduction of high-frequency recording systems at the end of the 2000s that the well-known examination type 4D motion could be introduced to the clinical user market. In the meantime, the technical possibilities and the associated software solutions are capable of graphically displaying the dynamics of a patient's spine with recording frequencies of up to 240 Hz and ultra-short exposure times of just 4 milliseconds in a smooth and fluid manner. These parameters even allow for use in high-performance sports with treadmill speeds of up to 30 km an hour. At this point, a short word about the use of a treadmill in the context of clinical gait analysis. The treadmill is a means to an end. It offers upsides but also limitations that every user should take into account. The advantages certainly include the fixed and small space requirements of a treadmill system compared to diagnostics in open space and fixed ground. In addition, the distance that the patient has to the measurement system is essential for the correct derivation of the three-dimensional data of the back surface. The patient can walk on the treadmill without moving from the spot. Your treadmill is equipped with floor markings that show you exactly where your patient should be placed to. In addition, you will see a preview image in the software as soon as the stride projection is switched on. This gives you a rough view of the analyzable area of the patient's back. If this is not showing the entire back surface, the wrong distance may be a reason. The patient will then walk outside the floor marks, either too far away or too close. In any case, the treadmill situation allows for a quick correction of the distance. Possible limitations resulting from the use of a treadmill are mainly of a coordinative nature. Lack of air resistance and the reverse spatial movement. The ground moves under me, I walk on the spot, often lead to an increased trunk inclination, a shortened stride length towards the end of the swing phase, and a compensatory increase of the stride frequency. Let your patient get used to the treadmill situation first and plan a few minutes for this habituation process before the first measurement. After all, you want to evaluate a gait pattern that is as habitual as possible. This also includes choosing the appropriate treadmill pace. Do not approach the choice of speed too timidly. Most patients will have just as much trouble establishing a stable gait pattern if the speed is set too slow as if it is set too fast. Observe your patient walking on solid ground. You also want to be able to observe this kind of gait pattern in the treadmill situation. Let the patient put his fingertips on the handrail to get used to it. This creates spatial orientation and initial stability. Inform the patient if the steps are too short and ask him or her to take longer steps. This usually leads to an approximate neutralization of the step length. When the patient shows a calm and harmonious gait pattern, the fingertips can slowly be released again and the arms can be set in motion. As soon as the arms swing in rhythm with the stride and the gait is not exclusively characterized by acceleration and deceleration phases, we are ready for takeoff and the recording can start. The calculated result data should now reflect the habitual gait in the best possible way. The results pages of a 4D motion measurement place the strongest emphasis on the representation of segmental rotation. There are two approaches to this. In the first case, we speak of the graph of surface rotation. Here rotation takes place in space. This rotational component shows the transversal orientation in relation to the gate direction. The graph shows the value currently valid in the timeline. The gray area behind represents the total range of motion measured in the surface rotation over the entire length of the spine model. With the ulterior motive that both eyes and feet will always adopt this orientation, this graph provides some important information about global and segmental rotation asymmetries. In many cases, symmetrical rotations around an asymmetrically positioned starting point can be observed here in particular. As an example, if L1 was measured in a static measurement with a spinous process rotation of 4 degrees to the left, then we would expect L1 to also move asymmetrically in a dynamic measurement. Let's say 9 degrees to the left and 1 to the right. The asymmetry should be obvious. But if we now include the already asymmetrical starting point of 4 degrees to the left, L1 rotates perfectly symmetrically to the right and left. At this moment, we know that bilateral segmental mobility is given. Asymmetrical constellations are compensated for as far as possible. The orientation of the eyes to the direction of walking can usually be ensured under additional energetic strain. An asymmetrical rotation compared to an equally asymmetrical starting point would therefore be a much more noticeable deviation. In the numbers game, L1 would now span its range of motion of 10 degrees between 4 to the left and 14 to the left. The rotation thus takes place to a greater extent on one side only. Sufficient compensation will still be possible in most cases, but the energy required for this increases exponentially. The underlying asymmetry can already be derived from the gray envelope curve for both examples. When it comes to the course of the red line, we enter a primarily subjective part of the analysis. When analyzing this line, always let the video run so that you can see the course of the movement. The still image of the red line can become interesting at a later stage, but usually only if the foot motion was recorded in combination with a foot pressure measurement and/or a video gate analysis. Let us come back to this in a moment. An important finding that has been taken up in the recent past in the context of scientific considerations is the model of impulse transfer. According to this, the rotational impulse is carried out in an ascending direction from the pelvis to the shoulder girdle. A fine intersegmental spiral can thus usually be observed well. However, since adjacent segments rarely show great differences in their rotational behavior, it is advisable, for the sake of simplicity, to initially think in terms of fixed segment blocks that rotate in the same direction, one after the other in ascending order. In each case, the pelvis forms the clocking block that initiates the visible rotation. Maximum pelvic rotation is normally observable at the end of the ipsilateral terminal stance. Caution: there's a small stumbling trap here. The lowest end of the surface rotation graph reflects the supposed pelvic rotation. In order to keep the graph consistent, the pelvic rotation is observed here in contrast to the real pelvic rotation from the back. So in the surface rotation, we are looking at the rotation of the DLDR line, which roughly corresponds with the transverse alignment of the PSIS. The real pelvic rotation takes the inverse of this. So if we see the lower end of the graph at 5 degrees to the right, this corresponds to a 5-degree alignment of the ASIS to the left. The lumbar spine follows this impulse with a slight time delay. This is followed by the lower thoracic spine up to a level at about T7 and 8. Interestingly, this is often also the position of the kyphosis apex in the sagittal plane. In a further offset, the cranial thoracic spine finally takes up the impulse. This happens at a time when the pelvis is already turning in the opposite direction. The harmony in which this movement takes place is an important subjective assessment criterion for classifying functional abnormalities. If the rhythm is disturbed, this can indicate a local blockage or coordinative disturbances that unnecessarily move the body's center of gravity out of its central position. This approach extends to the interpretation of individual, very local outliers that are triggered, for example, by segmental structural disorder. A tip. In DIERS 3 versions from version 3.14 onwards, the playback speed can also be varied via the video control. In some cases, the described sequence can be better derived in a slower display. This function is available in all dynamic examination types. In the context of clinical gait analysis, the movement sequence sometimes recedes somewhat into the background. In order to alleviate the complexity of the movement sequence somewhat, it is sometimes advisable to first concentrate on individual images at certain points in time in the gait. For this purpose, a specific point in time with an observable gait deviation is determined via the video control at the pedobarography or the video gait analysis. Switching back to the 4D motion then shows the exact spinous process rotation at the defined point in time. A red graph with local outliers or visible twists can provide a direct segmental reference to known symptoms. The second approach to visualizing rotatory activity is shown in the segmental pie charts to the right of the surface rotation. The display includes the rotation ROM of VP at the top and that of the pelvis at the bottom. Note, real pelvic rotation is shown here. The side indication here corresponds to the orientation of the ASIS. The dorsal gray area corresponds exactly in its width to the lower end of the surface rotation envelope. The extent of movement of the pelvis in rotation is probably the easiest parameter to comprehend. The expected pelvis range of motion is about 10 degrees in total. These 10 degrees are divided into 5 degrees to the left and 5 to the right, and, as already mentioned, are required in terminal stance. At the end of this phase, the hip reaches its maximum extension of about 20 degrees in relation to the vertical of the recording plane. This degree of movement is the sum of about 15 degrees of pure extension and another 5 degrees of pelvic rotation. This is how this calculation comes about. However, if the hip is not able to perform this extension, an increased pelvic rotation can compensate for this, which is often observed. In this case, the pelvis is rotated a little further in the transverse plane. The range of motion therefore increases on one side. The temporal sequence of the step development then allows a return from the increased rotation only up to a certain range. An increase in ROM on one side usually causes a reduction on the other. In total, it then remains at about 10 degrees again. It is therefore anything but atypical to observe an increased pelvic rotation of, let's say, 7 degrees to the left, in combination with a reduced rotation of 3 degrees to the right. In cases in which a ROM of 10 degrees is significantly exceeded or undershot are often far more conspicuous in terms of functional disorders and limitations. In the middle diagrams, the thoracic segment with the highest rotational excursion is loaded at the top and the corresponding lumbar segment at the bottom. By right-clicking on the diagram, any segment can also be selected for display. The extent of the rotational movement is also addressed in these diagrams. However, it is not the free rotation that shows the surface rotation, but the segmental rotation in relation to the pelvis. To assess this, we start from two ideas already mentioned. The pelvis is the starting point for rotatory activity along the entire length of the spine. Extending this, it could be added that an asymmetrically aligned pelvis is decisive for the asymmetrically shaped spinal rotation. This is contrasted by the tendency